And I'm really looking forward to this.
Great, thank you. All right, so I am here to introduce Dr. Karen Wolf. She is the head veterinarian at Point Defiance Zoo and Aquarium in Tacoma, Washington. If anybody wants to visit, our family has membership, so let me know. She received a master's degree from University of Maryland in partnership with the Smithsonian National Zoo, focusing on the reproductive physiology of the endangered black-footed ferret. She then earned her doctorate in veterinary medicine, DVM, from the Virginia Maryland Regional College of Veterinary Medicine. After receiving her DVM, she completed two-year-long internship, two-year-long internships, one in small animal medicine and the other in zoological medicine in Kansas State University. She then completed a 3-year residency program in zoological medicine at the North Carolina State University. Dr. Wolf is a board certified in zoological medicine. She serves as a veterinary advisor for the Association of Zoos and Aquariums American Red Wolf SAFE program, which stands for Saving Animals from Extinction. In this role, she has been investigating the prevalence and clinico-pathologic features of inflammatory bowel disease in this endangered canid. Additional clinical interests include developing innovative care plans for aging zoo animals and optimizing their well-being. Please join me in welcoming Dr. Karen Wolf.
Great, it's a pleasure to be here. I'm going to go ahead and start sharing my slide if that works.
Yes, go ahead.
Okay, can everybody see the image?
Yes, we can.
Great. Well, first I wanted to thank you for the invitation to share a little bit about elephant tuberculosis with this forum made up of public health professionals. And I also am grateful for the opportunity to talk about the emergence of MTB in our elephants here at Point Defiance in 2019, which involved collaboration with our public health partners to ensure human safety. So I do not have any financial or other relationships with any commercial interest organizations within the past 12 months. And our objectives today are to explore the diagnosis and management of tuberculosis in elephants and how that differs from humans and highlight the importance of collaboration across disciplines. I also am going to explain the modifications in elephant husbandry to ensure employee safety and to improve surveillance practices following the diagnosis of MTB in our animals. So I'm going to give a little bit of history about MTB in elephants. It is not a new phenomenon in elephants. In fact, it was thought that mastodons actually experienced tuberculosis, and these are the predecessors to our current Asian and African elephants. And it's an ancient disease, therefore, and it's also thought that perhaps it played a role in the extinction of the mastodons. And so even though TB can be traced back thousands of years, really the first published case report involved an elephant right here pictured. This is Jenny, who lived at the Zoological Society of London in 1875. And when she died, there was a case report written about her. TB has been documented in both the African and Asian subspecies of elephants. However, most recorded cases have involved the Asian elephant. And this is likely because of the close relationship between humans and elephants in the Southeast Asian range countries where they originate. The vast majority of TB cases in elephants are actually involving those animals that are under human care. And this again is likely because of the close contact between the two species. However, discouragingly, more recently, tuberculosis has been identified in free-ranging elephant populations, both African and Asian. And this may be another factor that's contributing to their demise. And that's really awful. And so one of the things is that there's a high prevalence of human TB in the range countries of Asian elephants. And so that could account for why Asian elephants are considered to be more susceptible to tuberculosis. It's because they're more frequently encountered. In their range countries, they work as working elephants in elephant camps, working with mahouts. They are used in the temples, and they are also used for tourist attractions. And all of these opportunities for interactions with people may increase the potential for disease transmission between humans and elephants. And as habitat loss brings wild elephants in closer proximity to people and also the animals under people care, it also increases their chance for encountering tuberculosis. Currently in the US, there are about 300 elephants that are managed by zoos within the Association of Zoo and Aquariums. And about half of these animals are Asian elephants and the other half are African elephants. And if you see older elephants in the US, you know that they were brought in from Asia prior to the CITES regulation where they were classified as endangered species. So in the 1970s, when they were classified as endangered, it stopped all the import of Asian elephants into this country. When you see younger Asian elephants, that means that they were born here and not imported. So talking a little bit about the prevalence, early retrospective studies in North American zoos likely underestimated the prevalence, and that was for a variety of reasons. One, it omitted privately owned elephants. There really wasn't any uniform surveillance measurements to detect TB, and necropsies were not commonly performed. So they estimated about a 2% prevalence between 1908 and 1994. Modern TB surveillance and management in the US began in 1996, and this occurred after the death of 2 circus elephants secondary to TB. This resulted in an elephant tuberculosis advisory panel being put together by the USDA, and they developed the first set of elephant TB guidelines in 1997. These guidelines provide recommendations for TB surveillance, testing, and treatment in elephants. And these guidelines have gone through multiple revisions as new information about TB in elephants emerges. The last published point prevalence for TB in Asian elephants in the US is 5.1%, and this is for the years 1997 to 2011. So we're going to jump quickly to clinical signs, and most TB-infected elephants do not show clinical signs at all until the disease is more advanced. Elephants with advanced disease can show exercise intolerance, anorexia, weight loss, and respiratory signs are rare. They can occur, and they can include dyspnea, expulsion of the mucus from the trunk, and coughing. And it's important to note that coughing is not something that elephants readily do because of the unique shape of their palate. Elephants tend to be primarily nasal breathers. And because of the lack of clinical signs, TB sometimes remains undiagnosed until necropsy. And the disease is most often found in the respiratory tract, though systemic spread has been noted. I just need to play with my slides here for just one moment. All right, we're going to talk a little bit about the diagnostic challenges when working with elephants. And some of these are quite obvious. The biggest one being that they're massive animals. Asian bulls weigh about 11,000 pounds and females average around 7,000 pounds. And here you can see our elephant manager next to Suki, one of our elephants. And you can just really appreciate the immense size differences. And this massive size of the animal precludes basic diagnostics such as stethoscope, listening with a stethoscope, or auscultation, and also prevents thoracic radiology, which are components of human TB medicine. There's also the complicating factor that much remains unknown about elephant physiology, immunology, organ function, and drug metabolism even. So extrapolations from cattle, livestock, horses, and other animals, and even people are often inadequate. Or inaccurate. And then the standard diagnostic assays that are used in people and other domesticated animals are also not validated in elephants or ineffective. The standard tuberculosis skin test, or the TST, which is widely used in people and domestic animals, is ineffective in elephants, and it causes non-specific reactions, thus is contraindicated. Other assays that are routinely used in other species are either considered experimental, not validated, or not widely available. And oftentimes the antemortem diagnosis of TB in elephants requires multiple diagnostic tools, not just a single method. And despite this, surveillance for tuberculosis is crucial, and it's an essential component of elephant health because of its zoonotic implications, and it must occur at a minimum of annually, depending on the risk category of the elephant. And I will talk about the risk categories a little bit further on. So I'm going to mention a little bit about the diagnostics of MTB in elephants. The diagnostic assays that can be used are either direct or indirect methods, and the direct method confirm the presence of the actual MTB organisms. And these methods include the culture of a trunk wash sample and real-time PCR or qPCR. The trunk wash is the gold standard for diagnosing tuberculosis in elephants. I'm just going to pause a moment. So this is an older picture. More appropriate PPE would be used. I've borrowed this from a colleague, but what you're seeing is that 60 mils of sterile saline is infused into one of the nostrils of the elephant. The elephant is then instructed to lift its trunk up in the air to help move that fluid into the respiratory tract. A plastic bag is then placed over the tip of the trunk. The trunk is brought down and the animal is asked to forcefully expel its contents in a plastic bag. And once this happens, the bags are collected and sent in more appropriate vials to the NVSL, which is the National Veterinary Services Laboratory, for culture and qPCR assay. The real advantage of this test is that a positive test is conclusive for infection. It's 100% specific. And also, you don't need to require sedation for the animal. Animal can do it without drugs on board, which is challenging in and of itself when you're working with an elephant. Another advantage is that you can actually isolate the genome. So once you've isolated the genome, you can send it in for sequencing and they can figure out more about where the organism originated. The disadvantages of this test is that it doesn't necessarily rule out infection. It has very poor sensitivity. So elephants may not be shedding at the time of the culture when they're asked to do a trunk wash, or they may be shedding intermittently and the test can miss the organism. The other thing that's complicating is that the culture often takes 8 weeks for the results to be returned. And additionally, if it needed any more complication, the procedure does require training and cooperation of the animal. So the samples can be collected with contamination because you're infusing the sample in the trunk. So there's an opportunity for other bacteria to be there, and those can mask the culture of MTB. And finally, of course, there's also the zoonotic potential for the handlers. So that necessitates PPE. So I mentioned another direct method, which is the qPCR. And a big advantage of this assay is that the qPCR results are available within a few days. You don't have to wait the long period of time. But one of the disadvantages is that used alone, it doesn't necessarily indicate an active infection. It just detects the DNA and it doesn't really tell you if the organism is viable. So really the combination of trunk wash combined with qPCR increases the sensitivity of the standard trunk wash. Some of the indirect methods that are used for antemortem testing include serology, and this includes the dual plate pathway and the MAPIA, which is the multiple antigen print immunoassay. And these tests use a chromogenic reaction to identify serum antibodies to specific mycobacterial antigens. And these tests are not recommended for regulatory purposes, but they are very useful as ancillary diagnostics. And the reason they're not currently used for regulatory purposes or to definitively classify an animal as being positive is because a positive exposure does not necessarily confirm shedding or active infection. Likewise, a negative result could mean that the exposure was too recent for seroconversion or that the elephant did not seroconvert. There's also been some reports of cross-reactivity with atypical MTB, such as M. solgai, and in some cases, an animal's age or health status may affect the results. And then if you have a treated animal, it's not really known for how long after treatment that they'll stay positive on these serologic assays. However, when they're combined with the direct methods, they can provide useful insights into an animal's status. And it could raise the level of suspicion of an infection so that the frequency of the screening and direct methods can be increased. So the clinician is alerted to that there could be an issue. And the last two methods I'm just going to really glance over, which is the cytokine stimulation assay and the elephant gamma interferon test. These are experimental in the United States and are not widely available, but they do show a lot of promise. And they are more readily available and used more frequently outside of the US. So I mentioned the guidelines for diagnosis and management of MTB in elephants, and that was put forth by the Elephant Care Stakeholders Task Force in 2017. And this group of people consists of veterinarians with elephant expertise, elephant managers, public health specialists, physicians, other professionals, epidemiologists, pathologists, pharmacologists. And these guidelines serve as a source of consolidated information for diagnosis and management of tuberculosis in elephant for the average elephant practitioner, if there is such a thing as an average elephant practitioner. The guidelines define categories and make recommendations for testing frequency and animal movement based on their risk category. And I mentioned those different categories earlier. So there's 3 risk categories for elephants. There's A, B, and C. Category A animals are considered low risk. They're trunk wash negative and have no history of exposure to an MTB positive animal within the last 5 years. These animals are screened annually with trunk washes and have no travel restrictions. The next category of elephants are category B, which are moderate risk animals. They're considered trunk wash negative, but they do have a known exposure to an MTB positive animal within the last 5 years. So what they need to do for surveillance is quarterly trunk washes for a minimum of 2 years. And if they're not positive during this time period, the frequency can be reduced. And if they're still negative after 5 years of trunk washes, they return to the category A or low risk status. And finally, there's the third category, which is category C animals, which are trunk wash positive animals. And these animals require trace backs to determine which elephants and which people this individual has contact with. And of course, travel is restricted. Also mentioned in these guidelines are treatment for elephants with TB. So I'm going to go over that really quickly. The primary goals of treatment in elephants is to rapidly stop the shedding of the organism and to achieve and maintain adequate serum levels of antitubercular drugs while avoiding their negative side effects, which can be pretty profound in elephants. There's a variety of treatment protocols, all of which use isoniazid and rifampin, but this is beyond the scope of this current talk. So when treating elephants for TB, human protocols are often used as the starting point, and plasma drug concentrations that are achieved in people serve as guides for elephants. It's also been recommended that the plasma drug concentrations reach a minimum of 3 times the minimum inhibitory concentration of the bacterial isolate. And so throughout the treatment, trunk washes are also monitored intensively because the only way you can know that treatment is successful is through lack of shedding. So treatment duration in elephants is usually quite prolonged. It's anywhere from a minimum of 12 months all the way up to 18 months. And after treatment, lifelong surveillance is required. Again, like the diagnosis of TB in elephants, treating elephants is also challenging for a variety of reasons. A large quantity of drugs are needed for treatment just due to the sheer size of the animal, and so bulk drugs are often used. And this poses challenges because you need to check for the drug purity. You need to ensure adequate supply of the drugs to avoid treatment interruption and thereby needing to restart or forming potentially resistant bacteria. And then you also need to comply with the FDA laws pertaining to compounding. And so treatment does require compliance from the elephant, and this is always phenomenal to me. They must be trained to take the pills by swallowing without chewing them or crushing them because of the poor palatability of those drugs. And it takes a lot of time to shape this behavior. So if you can imagine with your dog or your child, asking them to take something and swallow a medication, and it's usually, in our case, it was 48 pills that were about 3 inches in size. What you're seeing in this picture is I think it's a size 10 capsule. And you can see the 3 inches. And then here is one of our elephant keepers wearing a papper. This is when Suki was being trained to take pills. The pill would be placed in her mouth and she was rewarded with a juice in a syringe essentially. And then she would swallow that and take the pill. And so she would repeat this 48 times and be rewarded for that. And so that obviously takes some time. And one of the drugs, so again, in elephants may be different from people, I'm not sure. You can also give the drugs rectally. So if the elephant isn't compliant, you can give the drugs rectally. However, of course, this also requires training and it requires an appropriate setup for staff so that they ensure their safety. And then one of the mainstay drugs, rifampin, can only be given orally, so you can't get around it completely. And then elephant compliance is also really important because they have to be well trained for blood draws. So plasma drug concentrations for each drug for every elephant has to be measured because each individual elephant has significant variation in their drug pharmacokinetics, and the drug amounts often need to be fine-tuned for that particular animal. So if plasma drug levels are too low, there's a potential that the bacteria will not be eliminated and could develop more resistance. So you really need an animal that's going to participate in routine blood draws. If the levels are too high, there's a potential for toxicity. Additionally, elephants needed to be monitored throughout treatment because their health status needs to be checked, as elevated liver enzymes have been reported after treatment and during treatment. And in many cases, the drug concentrations achieved in people may not actually be achievable without resulting in toxicity for the animal. Signs of toxicity include anorexia, depression, colic, ataxia, blepharospasm, and epiphora. Additionally, even if behaviors are trained, if you have an 8,000-pound animal that chooses not to take its medication, there's not much you can do about it. So I'm going to circle back now after taking a quick drink of water and talk about the cases that we had at our zoo in 2019. So we discussed the challenges with diagnosis and management. So in 2019, we had 2 Asian elephants, Hanako and Suki. They were both geriatric, and we have a 29-acre park. Hanako was born in 1963 in the Pacific Northwest, and she moved to PDZA in 1997. Suki was born in Thailand in 1964 and was relocated to the US in 1965. She lived at several different zoos, spent time about 20 years in a circus, and moved from a zoo finally in the Midwest to PDZA in 1996. So both of these animals live in this habitat pictured here, and this barn is where they live. And the barn was constructed in 1991, and it was the first facility in the US built for protected contact management of elephants. And what this means is that the elephant keepers never share the same space. They never are in the same space together. These animals in our care have a history of antisocial behavior towards people and towards other elephants, so they're considered dangerous. And they need to be managed through protected contact. The barn is 2 stories. The lower section of the barn is dedicated to the elephant space and includes their bedroom. The upper level has office space for keepers. There's a catwalk above the elephants that allows for them to be monitored from above. There's an area for hay storage, and there's a food prep space. And at the time, in 2019, there was a single ventilation system that serviced the entire building. And I also wanted to mention that the elephants, while they lived together, were housed separately. They shared visual, olfactory, and tactile contact. And the reason for this was that Hanukkah was suffering some other chronic illnesses, and Suki was being too demanding and really kind of bullying her, so they needed to be separated. So at the time, tuberculosis screening for the elephants was performed annually using that triple trunk wash technique that I discussed earlier. And so we collected 3 separate samples during a 1-week period and submitted them to NVSL for culture and PCR. And then at the time, staff were screened that worked with elephants and other species such as hoofstock or primates that are susceptible to MTB or members of the MTB complex. They were also screened on an annual basis using the tuberculin skin test. So our washes were performed in March of 2019, and both elephants were negative at that time for tuberculosis. Screening for the staff was held in September 2019 and unfortunately yielded 2 positives. And this was out of 18 staff that were either elephant keepers, supportive elephant staff, veterinary staff, and 1 manager. So these positives prompted retesting of all of the elephant barn staff using the interferon gamma release assay, or the IGRA. And that yielded 6 additional positives for a total of 8 test positives. Of the 8 positives, 5 had tested negative on the TST. And 1 had missed the on-site skin testing, so her physician had actually directed her to be tested with the IGRA right away, which was indeed positive. And the time between the skin test and the IGRA was about 2 to 3 weeks apart. So it's important to note that there was no active cases of human tuberculosis. All were classified as latent, and all staff elected to undergo treatment. But in light of these positive skin tests, we repeated the trunk wash for the elephants, and both were qPCR positive and ultimately culture positive for MTB. And so this indicated potentially that the elephants began shedding sometime during that 6-month window. The genome isolates from the elephants were sequenced by NVSL and compared to other isolates in the NVSL database. And both of these isolates were identical to each other, but different from all other isolates in the database. And they were located in the lineage 4, which is the Euro-American lineage. After identification of test positive personnel, we contacted all the relevant regulatory agencies, and senior zoo management also reached out to the National Institute for Occupational Health and Safety, or NIOSH, to come on site to perform a health hazard evaluation so that appropriate actions and adjustments could be made in our protocols to keep staff safe. And then immediately after latent TB was diagnosed, additional biosecurity measures were put into place, including wearing N95 respirators and restricting barn access to only essential personnel. So this prompted a joint investigation into the cluster, and it was conducted by the Washington State Department of Health and the Tacoma-Pierce County Health Department. And there were the following goals: to determine the extent of the cluster among zoo workers, to identify the risk factors for MTB transmission from elephants to people, and to prevent future transmissions. The results of this investigation were shared in 2021 at the annual conference of the Council of State and Territorial Epidemiologists. The investigation included identification of people who spent greater than or equal to 2 hours inside the elephant barn between March of 2018 and September of 2019. The zoo offered IGRAs to all exposed people. DOH investigators attempted to conduct phone interviews of all identified exposures, and then individuals who worked in the barn or veterinary staff were given an additional questionnaire. So in total, 108 people were identified that spent greater than or equal to 2 hours in the barn between that time period. And of these, 71 people were interviewed and tested with the IGRA. Then there were 10 positive IGRAs, but 2 of those were excluded. 1 excluded because it was a prior positive, and 1 excluded because the person was unable to be interviewed. So that left 6 or 8 positive, and 6 of those 8 positive were Elephant Barn staff members with over 1,000 hours in the barn. One positive test was a manager with over 400 hours in the barn, and unfortunately her office had been relocated to the barn during renovation, and that's why that occurred. And then 1 was a volunteer with less than or about equal to 1 hour in the barn, but it's really important to note that this person had not been TB tested since 1980 and had an extensive travel history. So risk factors that were identified during this investigation were consistent with those that were previously found in other investigations and included close continuous contact with elephants, physical contacts with elephants, and cleaning or being present during the cleaning of the elephant barn. So of the 8 staff with the positive IGRA test, 6 cleaned the barn and 2 were present at least once while the barn was being cleaned. 5 of the 8 had continuous close contact with the elephants 1 or more times since March 2018. So now I'm going to jump back a little bit and go to the elephants. So at the time of the initial diagnosis, we elected to not treat them. Both animals were in their mid-50s, which is considered geriatric for elephants, and both had multiple chronic but stable health conditions that would make treatment potentially harder on them. Hanako had developed squamous cell carcinoma in one of her digits, and then she also had osteoarthritis and dental attrition. Suki was presumed to have uterine leiomyomas based on previous clinical notes from ultrasound evaluations, and because she had clinical signs suggestive of reproductive tract disease. Additionally, Hanako was not reliable for blood draws, which would make it very difficult to impossible to monitor her drug levels and organ function. Given that both animals could not be treated and could not be housed separately, treatment of only one was considered risky as there was concern for reinfection and ultimately development of resistance. So the federal, state, and county agencies were aware of this decision to not treat and worked with the zoo to make adjustments in our protocols to ensure staff and public safety. And these recommendations will be discussed next. So, and then concurrently with the investigation by DOH and Tacoma Public Health Department, NIOSH came on site and was invited to perform an assessment of the site and to look at our current practices so that adjustments in addition to those made by DOH and TPCD could be made in our protocols and infrastructure just so we can ensure staff safety and public safety. And the following recommendations came from their visit, and they focused on engineering controls, administrative controls, and enhanced PPE, some of which had already been put into practice. So they recommended adjusting the ventilation system so that the office and the elephant quarters were on 2 separate systems. They recommended designating a dedicated occupational health manager, improving the existing TB exposure control program, improving the respiratory protection program, revising the cleaning protocols so that aerosolization did not occur, so no power washing, and establishing dedicated PPE donning and doffing areas. So I'm going to jump to one of the most significant things that was put into place, and that's the change in the ventilation of the barn and access to the elephant area. So after TB had been detected, all staff were moved out of the barn right away into an adjacent trailer until renovations could be made, and the renovations weren't completed until February of 2021. But essentially, the barn was split into a people zone, which is green, and an elephant zone, which is red. And the dedicated human space has a completely separate air handling system, and the area was made positive pressure to the elephant area to prevent flow from the elephant area to the human area. And pressure monitors were installed to enable confirmation that the system is working correctly. Prior to renovations, there were 2 doors, and I've depicted here, that led from the keeper space into the barn, one from the office, which is here, and one from the hay room. And this ante-room and vestibule did not exist, so it went directly from the hay room into the elephant barn. These were replaced with newer, heavier doors that had a better seal. And the door from the office now is not allowed to be used. It's only used if there's an emergency. And then the 2-room vestibule that I mentioned was placed here, which consists of a papper room and an anteroom. And so in order to enter the elephant space, a keeper has to first enter the papper room and don appropriate PPE. Then they need to close that door after they enter the anteroom and ensure that the door is closed. And then once that's closed, they can go from the anteroom into the elephant space. And then the door of the elephant area is not opened until that previous door is closed. And then when coming the other direction, the process is reversed. And so right now, the anteroom is the only daily route between the elephant area and the human area. The air in the barn is changed approximately twice an hour, and the air from the barn is also now vented out of the top of the roof rather than the side, and this is exposing the bacteria to radiation. There's also a purge button that completely cycles air out of the barn within about 10 minutes, and this is used prior to staff entering the barn first thing in the morning and after completion of hosing for the day. And what you're seeing here, this is that walkway I was talking about, and so over here is that anteroom area, the space that would come around here, and then over this way is the keeper offices, and this door is no longer used. And below, pictured here, is where the elephants are housed during the day and overnight. Oops, let me go back. So the first line of defense that was implemented occurred immediately after the suspicion of TB in the elephants, and that was to restrict access only to the essential personnel. And this includes keepers, veterinary staff, and area managers. Any other staff, such as maintenance staff or outside personnel like fire marshals, are only allowed inside after Suki has been out of the barn for 2 hours and 2 hours after any hosing is completed. Anyone entering the barn outside of essential staff must also sign a visitor log and wear appropriate PPE. Initially, that PPE consisted of N95 masks, and PAPRs were only used during hosing, but as you'll hear later, this changed. Employees are informed and trained on the potential work hazards when working with the elephant area and receive on-site training for safe practices, procedures, and protective measures. And this information is also included in job descriptions and discussed with any potential new candidates. Employees are given the opportunity to be reassigned if they do not wish to work in the elephant barn. We've also designated an occupational health coordinator, and this person oversees the TB surveillance program and ensures that appropriate documentation is obtained. And this includes scheduling and documenting baseline and follow-up TB testing and results. The TB surveillance program also went through significant modification. The TST, or the skin test, was replaced with IGRA testing. All new employees are screened using the IGRA test. And at the start of our program, all elephant barn employees that did not have latent TB were screened quarterly with IGRA. Ancillary staff who did not work directly in the building daily were screened twice a year. And then all employees that worked in the elephant barn that were diagnosed with latent TB receive quarterly symptoms check. And this is done by a qualified healthcare professional. And then other staff that work with primates or livestock still receive annual testing. And then the respiratory protection program was assigned a designated administrator and includes regular fit testing and training on proper PPE. In addition to all of these changes, many barn protocols were changed, and this include reducing the amount of aerosolization with cleaning by not using the high pressure hosing and changing our disinfection protocol. And so, in summary, a TB exposure control program was put into place with a contracted industrial hygienist to outline the administrative controls, PPE, facility upgrades, and ongoing activities. And this work group consists of representatives from operations, staff administration, veterinary staff, and a contracted public health nurse. And it originally met monthly, and now that things are more stabilized, it meets quarterly. So I'm going to go back and talk about additional changes after I take another quick sip of water. Changes that have occurred since TB was first detected was that unfortunately Hanako had to be euthanized due to her declining quality of health. It wasn't related to the tuberculosis, but the squamous cell carcinoma in her foot had progressed to the point where it was really impacting her quality of life, and humane euthanasia was the best decision for her. Unfortunately, a month after Hanako was euthanized, an additional staff member who had spent time in the barn tested positive for latent TB. This conversion led to the requirement that treatment be initiated in Suki. Additionally, all the people entering the barn were required to wear PAPRs. No longer were N95 respirators permissible. So now anybody in the barn always wears a PAPR. So Suki was trained to take voluntary pills within a 5-month time period. That's how long it took to shape this behavior of swallowing the pills. Her behavior was very solid, and was solid enough to begin treatment in November of 2020. But unfortunately, she quickly began to experience adverse side effects, and she was intelligent enough to associate the pills with feeling ill. So she started to refuse to take the medications, which was one of our fears. So she wasn't taking them through the trained behaviors, but we have very clever and creative keepers. And so they started hiding her pills in food. And so they placed them in about a variety, I'd say over a 6-week period, more than 90 different food items were used to hide pills and get them to Suki. But after 7 weeks of treatment, she had had enough. She refused to take pills regardless of what they were offered. And during this time period of treatment, she lost 500 pounds. She was lethargic, inappetent, and developed raised cutaneous lesions. So once again, we approached the Pierce County Health Department, and given that the barn protocols had undergone significant renovations and treatment had been attempted, Pierce County Health Department officials approved the management of Suki without medications going forward. So our current surveillance program is as follows. All new employees still receive the IGRA testing. Quarterly symptoms checks are still being completed for individuals with prior test positives. Elephant barn employees that were test negative receive twice yearly IGRA testing, and ancillary staff, including the vet staff, receive annual screening. All hoofstock and primate keepers receive annual screening as well. But if an employee does not work with elephants, primates, or hoofstocks, no further testing is required after their first initial IGRA screen. There have been no additional people that have tested positive, and no one that previously tested positive has developed active disease. One staff member recently had her first baby. Suki has since turned 59, and you can see them each holding little cupcakes for Suki. And she's receiving regular health checks. Her quarterly blood work has shown some signs of chronic disease, and this includes anemia, hypoproteinemia, and changes in her acute phase proteins. She's also starting to show more signs of her age and arthritis. Overall, her condition is considered good, and she's bright and active, especially for an animal that's almost 60 years old. She receives comprehensive daily quality of life assessments to monitor trends over time. This scoring includes mobility scores, sleep duration, whether she lies down during sleep, her appetite, etc. And we have an elephant management team that meets monthly to discuss her status. So the open communication between public health officials from the county, state, and federal agencies and zoo professionals allowed us the opportunity to pool our expertise across multiple disciplines, and ultimately human health and safety is being maintained while not compromising elephant well-being. We realize that the solutions that have worked here at PZA may not be replicable elsewhere. Our situation is unique in that we had 2 geriatric animals that couldn't be managed with other elephants. And right now we have Suki, and she is an antisocial elephant that does very well being a singly housed elephant. This has allowed us to manage her without treatment, which when attempted caused serious adverse side effects and was unable to be completed. We're confident that the renovations and safety protocols that have been put into place with the help from our partners from the public health sector will continue to allow her to be managed optimally while maintaining human health and public safety. So in conclusion, I hope this presentation has provided some useful information about elephant tuberculosis in general, and some information about the Point Defiance Zoo and Aquarium current elephant status and our TB preventive program. And I am able to take questions.